case-based rehab for different patient. Before I start, let me introduce our speakers. Our speakers are from various parts of the globe. First, Dr. Amar. He's MPT Neurology. He has been a former Director of Physiotherapy Rehabilitation Department, Felix Hospital. He has 1 patent, 11 presentation, and he has a very good amount of knowledge and experience which he'll share when he's presenting. Dr. Shashi, again, he's been with us for, he was with us for last 15 years. Presently, he's in Auckland, New Zealand. He has been to Dubai, and he has expertise in upper limb rehabilitation. Vineet is again trained in UK, US, UK, India, and Singapore. Presently, he's working in Singapore. He has a clinical experience of more than 17 years. Rajiv was trained in India, but presently he is working in Dubai, and he has good amount of experience and knowledge which he'll share with us. Sheetal is occupational therapist. She has been formerly at AIMS Rishikesh and Delhi, presently working with us. She'll be presenting her case. Dr. Akram is one of my colleagues. We both are working in Max Saket. I'll not go into introduction. First, we'll say why we are doing this course, or why we are doing this webinar. Because we don't want any miscommunication. Something like this, reference to physiotherapist, not check nice pussy, I'm thinking of something else and other person thinking of something else. So what happens when there's no formal communication between therapist and surgeon, the results are suboptimal. So we don't want such kind of misunderstandings. So for that, we would like to work as a team to give best results. Before, I don't want to waste more time. I just would like to come to the first case. First case we are presenting is 45-year-old male with a history of fall 4 months back. Initially, this patient was treated conservatively. On examination, there was impingement was there. Active abduction was weak. Internal rotation was painful and weak. Again, belly press sign was positive. MT can sign was positive. MRI showed supraspinatus complete tear, subscapularis tear, and there was no fatty degeneration in the muscles. Muscles were good. So patient was taken for arthroscopic repair, in which first we do the busectomy. After doing the busectomy, this is removing buccal tissues. We prepare footprint. Footprint is the bone where tendon was initially attached. So you prepare the footprint so that create a bed for attachment of the tendon. Then because there was some amount of stiffness because there was 4 months patient was not moving it. So what we do, we just go between the rotator interval and release it to get some amount of external rotation. And we release the subscapularis so that muscle which is torn and retracted can come back onto the lesser tuberosity. So the muscle is released arthroscopically. Once release of the muscle is done, then we insert an anchor into the bone. Advantage is once we use metal anchor for the subscapularis because angle is little bit acute, so we don't want to use bio anchors here, but can be done. It's not impossible, but metal anchors make life a little bit easy. Once you put in your anchor, you have to take a bite into the, this is how we take bite into the subscapularis. You can see we're taking bite into the subscapularis, and once we tie a knot, the tendon sits on the lesser tuberosity, so tendon is repaired. So similar procedure is done for supraspinatus muscle. Supraspinatus muscle, we usually do two row repair because if retraction is not much, we want to give a double security, plus you want to increase the contact at the front footprint. So this is the second row in which first we have taken a middle row, all the bites. Once we have taken the bites, then individually we tension the threads. You can see as we tension the threads, the tendon sits properly on the bone by increasing the tension. So once we have done that and the tension is adequate, you can see this, as we just pull this thread, the tendon sits on the bone. So sequentially, we pull all the threads to increase the tension. Once we have done that, then anchor is inserted. Once tension is achieved, then anchor is inserted on the greater tuberosity. So in this case, we had one anchor on greater tuberosity and three on lesser tuberosity and three anchors on greater tuberosity. So it was a good repair. The quality of tissue was good. So patient was discharged with the shoulder immobilizer at first 1 week follow-up visit, first follow-up visit. Dressing was changed and patient was referred to for physiotherapy, in which the following information was given: that subscapularis repair has been done, double row repair, which is very secure, and tendon quality is good. So we can mobilize the patient early. So I'll refer this patient to Vineet. Vineet will take over from here, this patient. So Vineet, can you start your presentation, please? Vineet, can you unmute yourself? Yeah.
Okay. Good evening, everybody. This patient is being referred after a surgery 1 week ago. So I have treated this patient for almost 5 months, and this patient has been presented to me. Dr. Vikas has shared that the patient is a 45 years male. He is a bowling coach, injured his shoulder 4 months ago during intensive training session, and he reported pain, swelling, and loss of movement, which MRI show full thickness tear in infraspinatus and subscapularis tendon and swelling in the joint. So no other associated injuries was involved. So he was operated 1 week ago by Dr. Vikas, and he likes to do swimming and gymming exercise. So in addition to that, we have checked with the surgeon regarding his about the quality of his tissue, which is good, and he's having a double row fixation, and he have no fatty infiltration in his muscles. That's his quality of his muscles also good. So there's no secondary procedure was done. So okay, so the patient come to us in the first day to our clinic, and with having a arm sling. So and patient having on first day when the patient came, he had a lot of queries, bit of fear, and worried about whether he can back to his bowling, whether he can back to his normal lifestyle, and he feared that my shoulder is very painful, jam. He was not sure whether he can able to move it, and if he move it, is pain. And pain will the repair is done, is going to be injured. So a lot of questions are he having, and he was very fearful. So is expected, which in our experience is expected. Patients are very fearful on this timing. So we educate the patient on this session. We explain to them about this process of rehabilitation, how roughly take to get back to his original lifestyle. So it's roughly 5 to 6 months based on their potential. And we also explain that pain will be lasting for a few weeks, up to 6 weeks, and he need to use the sling to protect his repair, and he need to participate in our rehab program. And and we diligent in our physio sessions. So these are so we explained to him that our phase is into three parts. Phase 1, which is last for 0 to 6 weeks. We started before we starting the assessment to him. I also educate about him about how the principle of our rehab work to getting the normal movement. He need to reduce pain, range of movement, muscle power. He need to have a muscle flexibility and in timing of muscles to get his return to his normal activities. And the quality of tissue is good, and quality of repair was good as well. There is no associated structures. So, and that means he's quite good candidate to get back to the return to his activities in time frame. So, and we also explained to him there's a zones. We have divided some zones to which zones are safer to move. So, according to these diagrams, we showed him that zone A is quite safe. He can move his arm into the 90 degree, up to 90 degree. Zone B is less safe, which he can able to move it, but with caution. And zone C is the not safe, so he should not move above the head. So during the first 6 weeks, so this is the different side angle. He can bring the inside the arm, but can outside the arm, but cannot beyond the 90 degrees. So which can stress this which is stress the is repaired tissue. So repair tendon means it can be harmful for him if we move it. So he understood. So first 0 to 6 weeks, we started with him some gentle range of motion exercise passively. This phase we focus on passive exercises and assisted exercises. So we taught him some pendulum exercises with the standing with slightly bent, use his arm with gently with moving around clockwise, anti-clockwise, forward, backwards, and swinging back and forth. So this helped him to reduce his pain as well and reduce his swelling. So, and we also check his scapula, which is a quite important part for rehabilitation, which looks winged and is not sitting nicely. So we start some scapula setting exercises in this phase. And as well, we also started active assisted exercise with the help of the rod or some stick to help him to take it to get him the movement up to the level of pain he achieved, which we advise should not force it and push it if it's the pain don't allow. Okay, so this is our exercises we teach him on the first 6 weeks. Also, first 6 weeks we also emphasize on the thing which he supposed not to do. That first thing is the pain. Okay, pain is considerably there if first 6 weeks. So we apply to do the ice regularly or take the painkiller if come for the therapy session. So patient normally respond very well with the ice after the session and during his home exercise program. So we also advise you should not do end range of external rotation by side and abduction in first 6 weeks. No heavy lifting in 6 weeks. No end range of movement allowed in the first 6 weeks. So these are important because if these are not followed, it may re-rupture the graft area. So it can be more problem for the patient. So we move to the second phase, which is the 6 to 12 weeks. We again focus on the getting back to range of movement. In this phase, is the active movement is started, and we expected to full range of movement. And we starting to getting patient to get some strengthening exercise, light strengthening exercise, some endurance exercise, and flexibility exercise, and to increase his functional activities. So the patient will given some sort of stretching exercise, not the end range stretching, some within the limit range to help his range of movement. And strengthening, we start the light TheraBand, light dumbbell to start with the strengthening exercise. So dumbbell can be weight of the 1 pound to 2 pound based on their strength at the period of time. So they can start the repetition for the 10 repetition, 2 set of 10 repetition, 2 to 3 times a week. And in this phase, we also allow some gentle mobilization to allow to help the movement, because this phase, you patient still have the restriction in the end range. So we do some gentle mobilization, soft tissue release, so helping to release these tension in the muscle and range of movement, and help in the pain as well. So again, the strengthening exercises is continuing, which with the light resistance exercise band, we can do the scapular strengthening exercises with the band, tying the band. We also taught the patient to do exercise at home. We provide him the band and teach him how to do this band exercises. We took the videos of the patient by doing this, ask him to refer to his video while doing this exercise at home. So show that this will remind him if we do correctly exercises, and make sure he maintaining the repetition and progression accordingly. And we also teach him some of the stretches he can practice at home, like these stretches, which also help him to maintain his tissue, his tendon flexibility. So that is in the sideline. So now with continuation of second phase, and we starting with doing the phase 3. Patient was responding well until 16 weeks, and he had visited doctors into 3 times. And then during that time, he was cleared by doctors. Everything is okay. And he already, means first 6 weeks, he already removed the sling, and he looks more confident, and he looks looking forward to get back to his normal lifestyle. So we reduce this frequency of session to 1 time a week in the third phase. First phase, we did more intensive physiotherapy 3 times a week. Second phase, we did physio for 2 times a week. And third phase, we started physio for once a week. But in addition to that, we emphasis on the lot of home exercises he need to do. And we have to keep communication with us for any issue with the exercise program or any other issues. So in this phase, third phase, which lasts for 13 to 20 weeks, continuation of strengthening exercises, endurance exercise, and power. So since patient went for operation, he was a bit deconditioned, so his endurance also not good. So we encourage to do him some cycling, treadmill, some normal jogging, to start with some endurance exercises. Since he is a sort of very active person, so this kind of thing will help him to get back to his activity. And so that's why he liked to do. And in this phase, we started to do some swimming as well, some breaststroke swimming. He liked to do swimming, so make sure not to do overhead shoulder movements, which not stressing his joint. So, and our aim was to get back to his full activities and recreational activities and sports by the end of this phase. So strengthening exercise continue with the higher resistance band, which is the different color, and more repetition, more number of sets. And we taught him the similar exercises, but we increased the repetition and some set of exercises. So you see that dumbbells can increase the 4 pound to 5 pound, and you can see the scapular exercises he's doing in this position. Okay, in this phase, very important concept, we like it, the open kinetic chain exercises. We added these exercises in this phase, which help in the patient joint sense, and helping him to move the shoulder joint better when he's going to overhead activities. So he can do with some of the gym balls or Bosu balls, or he can use the weights. This is called open chain, means his end is not fixed. This is the end is fixed, means his proximal and distal end is fixed, and using the equipment. So it's a closed chain which put a pressure on the joint, which can help him to get some sensation. So giving him the good feedback to his joints, which can help him to move better. So these are the other closed kinetic exercises, which have a 4-point, 3-point, 2-point, and you look at the Bosu ball, which he able to do it, these exercises in this form. So so kinetic chain rehabilitation is a very important concept in the rehabilitation of the sports injuries, and those who like to go back to the overhead sports. So in this concept, we explain to him this: your force is where, if you go to the bowling, your force is coming from your legs and goes to the trunk and goes to the shoulder and and is passed to your hand and elbow and wrist. So, for example, he's a bowler, so his bowling is force is not coming from the shoulder head, his force is coming from the ground. So, from the ground reaction force. So, this means the component in this phase, your leg, your trunk, your thoracic, your shoulder is all involved. So, we not only focusing on shoulder, we have to look at is the legs, muscles, flexibility, strength in the core, especially core, which we can help him to generate the force in the shoulder if we need to throw a ball. So he understood this concept, and we edit all the programs will help to rehabilitate all these muscles, the core muscle exercises, leg strengthening exercises, some more and back exercises. So we holistically work on his rehabilitation on his shoulder. So these are so at least he can back to his sports. So eventually we work on for at least next few months, and then at the end of the five months, he able to back to the light training, and he can throw the ball, and he start doing the training with his students, and he himself going to throw. Then after around the end of the 5 months, he able to throw a full ball, and he continuing the strengthening and power exercises, and he normally don't he coming to us once a month or 2 times a month when he required any suggestion. So he's quite discharged from our side, and he's getting back to the full training schedule. So the general guidelines for the return to the sporting activities for the after rotator cuff arthroscopic repair, this is the driving. The patient can be start 6 weeks, swimming can be start by breaststroke into 6 weeks, freestyle can be 3 to 4 months, golfing can 3 months, lightweight lifting 3 months, throwing and tennis 5 to 6 months, return to work, sedentary job 3 weeks, but need to discuss with the surgeon to safe return to the sporting activities. So this is my summary for this patient. So this patient should be rehabilitation should be individualized and specific, and understanding of anatomy, biomechanics, and type of surgery is important for rehabilitation, and regular constant communication with surgeon regarding rehab progression. And I took some reference. I took some pictorial illustrations from these of the sites, and I didn't use my own patient because of the PDPA Act, so I have referred to these sites for illustrations. Thank you.
Dr. Vikas, kindly unmute yourself.
Before we go to Dr. Akram for next case, Amit Kardam has asked one question. I think it is towards myself, that when do you use ice and when do you use sling after surgery? Actually, we use ice when there's a inflammation or pain is there, initial phases, maybe up to a week, but a few days only. Sling is dependent upon what type of repair and how good our repair is. If our repair is good, we mobilize early. Depending on if patient is old and tendon quality is not good, then we can keep a sling for 1 or 2 weeks with intermittent exercises. Like intermittent, we can do pendulum initially, don't do active assisted initially. So I think that answers this question. So I'll not waste time. Dr. Akram, we can start with your next case.
Yeah, so the next case is going to be a elbow case. He's a 25-year-old male presented to us with a stiff left elbow, sustaining an injury about 6 months back, injuring his left elbow in a motorbike accident. There is a doubtful history of whether there was a fracture. Patient doesn't carry a record. He says that I was treated in a cast for 7 weeks by a local practitioners. Now he's not able to do the activities of daily living with this limb because of his stiffness. We measured the preoperative range of motion, which was to be 60° to 90° in the flexion extension zone. However, pronation and supination were full. We decided to undertake this patient for arthrolysis, and intraoperatively before surgery, we assessed his range of motion anesthesia, which was actually only about 60 to 90°, which was not going beyond. You can see two hands trying to gauge full movement. Intraoperatively, when we did a release from the medial aspect after releasing the ulnar nerve and anteriorly transposing it, we were able to achieve remove most of the fibrotic scar from the elbow from using the medial approach, and we were able to gain full movement. You can see on the left hand side top with a full extension was achieved, and on the right side down full flexion. The patient's hand is reaching up the mouth, and see this is full. With this, at fifth post-operative day, patient was sent for rehabilitation. The aim is to achieve full motion as much as is gained in the OT. Now, I know Shashi is waiting for us in New Zealand. It is 2 o'clock, almost 2 o'clock in the New Zealand, 2 o'clock in the midnight of New Zealand. So over to you, Shashi.
Thank you, Dr. Akram, for
Let me stop.
giving me the opportunity. So this is the case of elbow ortholysis, and I'm going to share my case, what I have done in physiotherapy. So here is my slide. So this is the case of elbow ortholysis. On the 5th day after dressing, doctor sent it to me. And the first thing I just asked about the case with the surgeon, that is there any joint instability or the fixation is good? Is there any nerve injury like ulnar nerve or any associated ligamentous injury? So it all was fine. The quality of bone and muscles is also good. Scar is healthy and skin integrity is good. Any associated, no associated problem as such blood pressure or diabetes, since he's a quite young patient, he's totally fine. So on the 5th day, I checked for the few initial assessment. Patient came with me the temporary cast with the dressing. The sling is given thus to protect the elbow joint. Some pain and swelling was present in forearm and along the wrist. That's normal. Some weakness in the muscle and some functional limitation because still dressing is on. He complained about some sleep disturbance because of pain, and he was a bit anxious. So that was the brief assessment on the 5th day. So I start the treatment by advising him about how you keep the arm and your elbow in a position to reduce the swelling and heaviness. So just keep arm in elevated position so that the swelling reduced down by means of gravity. And since shoulder and wrist joint is not involved, so right from the 5th day only, I start strengthening exercises for both joints. Elbow joint, we did pain-free active assisted exercises. Pain score is usually 4 or 5 out of 10. So this is the pain score, what we can go with the movement. Biceps and triceps isometric contraction is equally important, like 4-5 seconds hold with at least 30 reps, 10 reps into 3 sets. Some home exercises plan I taught on the first 5th day itself, like wrist active exercises you can see in the picture, and this shoulder elevation exercises on the bed. So that the wrist and shoulder should be uh, free, range should be full, and strength should be perfectly all right. What the joints are not involved, that is shoulder and wrist. So usually stitch removal is done on the 14th or 15th day of surgery. So on that day, patient came to me, and the first thing I did, that is elbow evaluation score. That is the evidence, documented evidence for the physiotherapy department. It consists mainly pain score out of 10, activity level, strength and range of motion. Some swelling was present, some tenderness. He complained about some tenderness. Temperature was definitely high because still under the surgery influence. This is the turnbuckle splint, turnbuckle brace, basically what we usually give on the fifth day itself. So this is the brace what patient usually do actively at home, flexion and extension movement. So this is the metal rod. We can screw this knob up and down like this way, so it moves up, that is flexion, and when it this knob and this it goes down, we can keep it straighter. So what I advise patient, you have to do this exercise at home every 2 hours, at least 30 reps. Some limitations of users of arm because of pain, that so I told them just to do the active light exercises like writing something, tearing a paper, cutting with soft vegetables, so that he can be able to do. So now the physiotherapy between 2 and 6 weeks, that's very important phase, because this time we have to get the best range, because healing is going on same time we have to go for the movements as well. So the visits usually 2 to 4 visits per week. Duration of the physiotherapy treatment with physiotherapists, with me it was about 45 to 60 minutes. First thing, very important thing that I do is scar mobilization. Scar mobilization is something deep transverse friction massage, some picking up. This is the picking up technique. So what it loosens the scar and releases the tension in the muscle, so that we can get the best range and reduce the protective muscle spasm. This is I am doing kneading. So this is the kneading technique. The second thing is lymphatic drainage. Lymphatic drainage usually I do from the distal to the proximal part. But before starting the lymphatic drainage, we have to activate the lymph glands around the medial aspect of the elbow joint. Then lymphatic drainage we do 3 to 5 minutes for the forearm muscle, so that the all excessive fluid what was stagnant in the forearm, that drain out towards the from the lymph glands. The second is the third one is I continued with the manual resistance exercises for shoulder and wrist joint, since it's totally fine. The next I start doing the passive elbow mobilization within the uh, greater range, that is 20 to 100, but definitely it all depends on the level of pain what patients feels. The few techniques I use usually I did, that is rhythmic stabilization. This is rhythmic stabilization. Here I am doing rhythmic stabilization. So in rhythmic stabilization, it's isometric contraction and relaxation of triceps and biceps. So there is no movement at all, only the form isometric contraction of the both muscles against the physiotherapy resistance. This is called rhythmic stabilization. The second technique is reciprocal inhibition technique. This is I am doing reciprocal inhibition technique. In this isotonic movement, contraction of the biceps and triceps. So you can see the visible movement here. That is what happens when we contract the biceps, tricep must be relaxed and the vice versa. So it finally uh, train both muscle in a very coordinated way, because our aim is to get the both range, elbow as well as flexion. As doctor told, it's 30 to 90. So we have to get it 0 to 135. That is average on an average normal range of motion. So these three techniques I am doing. The few VNF techniques also I did, that is hold relax. Hold relax is 10 seconds, 10 to 15 seconds of passive stretching, followed by relaxing of the muscle. The contract relax is the isotonic contraction of the muscles. But before that, every time physiotherapists need to do the stretching for 10 to 15 seconds. The third technique is hold relax antagonist contract. In this again here, I am showing for triceps. So here passive stretching of triceps followed by relaxation and followed by antagonist muscle, that is biceps here. This is biceps. So followed by contraction of the biceps muscle. This is called hold, relax, antagonist, contract. Here I am doing elbow muscles for elbow joint, the manual isokinetic exercises and resistive exercises. So manual isokinetic exercise, something is that physiotherapist manual resistance should be well calculated so that patient is able to do the best range. So it should not like that we are putting more pressure or more resistance, he won't be able to do. That's nothing, will not get anything. So it should be very calculated so that patient will be able to do the best range. Followed by the end range, we have to do in the end range the same exercises, just get the best end range. Here I'm doing that, and here you need to again continue with the same therapy, same technique. This is the technique. Frequent rhythmic relaxation is the it's in between the physiotherapy session. So what we do 20 to 30 reps of frequent rhythmic relaxation. It's just to and fro movement of the elbow joints. You have to grab from the forearm and to have to and fro movement of the elbow joint, so that muscle, especially biceps and triceps, it relaxes its own, and it by means you reduce the protective muscle spasm. Because what happens when you do the exercise, when you do the physiotherapy, because of pain, sometimes patient gets protected their muscles, so they won't allow actually to move further. So if you are pushing that time, it's not recommended. So better in between you just frequent rhythmic relaxation, and then you can easily get further 5-7 degree. So this is a very good technique actually. On an average around 5 to 6 weeks, we can advise them to activity based exercises like swinging the racket, dribbling some ball, soft ball at home, throwing and catching the ball with partner, with friends. So it gives patient the functional movements of the elbow. Here, this is the exercise of the tricep exercises with the dumbbells. That also I advised him to do at home. So now the next post-operative phases between 6 to 12 weeks. So this 6 to 12 weeks is the frequency of the physiotherapy here at the center. Maximum 1 to 3 even. I wrote it 2 to 3, but 1 to 3 visits is also fine. But it depends how patient is doing at home. If patient won't be able to do at home, he needs to visit the physiotherapy. But usually my patients he did as well. So at this phase, gradually increase the resistance level at its maximum and focus the available, definitely what we got it already by end of 6 weeks. So we have to maintain that range. We have to strengthen the muscle in that range. Apart from that, the last degree in the extension of the elbow as well as the flexion of the elbow, you can say 5 or 10 degree, we need to work hard on that degree. So what we do, I focused on the same techniques, but I just focused on the end range. So available range, we have to maintain with the resistance exercises, progressive resistance exercises, isokinetic exercises, and focus all techniques on the end range, both sides. So these are the 2 points. Other thing is start with the wall push-ups exercises, and now this is the incline push-ups, and by end of 12 weeks, he should be able to do the prone push-ups on the floor, basically. So this is the best way to do to strengthen the triceps muscle. And triceps is, triceps is responsible for the extension. This is the best exercise. So usually I recommended this exercise every time. This is the rhythmic alternate movements. The one movement I would share that is pronation with extension and flexion with supination. This is the physiology of the elbow. So this is the very rhythmic alternate movement that should be do at least 6 to 80 reps per day, 20 reps in a single set. So or a sports activity, related activity. If someone is playing some sports, some patient is playing some sports, I advised him to, you can start by 12 week, or I just coordinate with doctor whether he can start or not. So usually by end of 12 weeks, arthrolysis patient can start the sporting activity if he plays some games. So few advice to the patients I would like to share here. So believe in yourself, and since most of the time ortholysis patients are, it's not like straightforward case, like patient just injured and he thought, oh, I should go for the surgery, and the surgery has done. No, usually patient wait, they frustrated, they roamed here and there, local doctors. Sometimes ortholysis patient had the past surgery, history of surgery that failed. So I usually tell patient, believe in yourself and follow what the physiotherapy exercise regime with a positive attitude. This is very important. Engage yourself in your work, hobbies, whatever you are doing. Don't engage only in the physiotherapy or exercise. So it works in a different way. And patient can do some self-centering techniques, like just focus on your targets for goals you do just to achieve that goal. So these are the better techniques. One thing I would like to tell here: every day will be a better day. This should be the slogan. So patients should believe in that. Suppose today you are getting 30 to 100 degree, 20 to 100 degree. Definitely after a couple of days or maybe next day, you feel much better than that what you were before. So if you keep continuing the exercises, you follow the physiotherapy plan, definitely every day will be a better day. And in case sometimes you do the exercises, you are doing everything good, but sometimes there may be some excessive pain, some swelling, some unusual pain, sleep disturbed, you are going right, but one night you're just out of the you know so in that case you need to consult your doctor or physiotherapist, ask them whether it's okay or not, what should I do, what should I not do. So, and the last thing, do not exert yourself in a single stretch while doing exercise. It means don't go for the uh, 2 hours exercise continuously. No, you should be do like 15 to 30 minutes, few sets, 3 to 4 sets in a good way. Okay, if you don't have time, at least you do 2 sets, 2 times, morning, evening, but not like 30, 45 minutes. That's good enough. If you are doing 2 hours, 3 hours continuously in a particular group of exercise, for you are just running behind the triceps only, it's not a better idea, because muscle gets fatigued and you get exhausted also. So just enjoy the exercise, change the regime, circuit training, you feel better and you will be all right. So this is my advice, and this is done for my presentation. Thank you so much.
Thank you, Shashi. Before we go on to next case, any questions to Dr. Shashi? Anyone wants to ask questions? Okay.
Question for Vineet, if he's here to answer.
Vineet, I think we'll take questions later on.
Yeah.
Yes, I am here.
Yeah, Vineet.
What is the general advice about sleeping posture during first 6 weeks? See, most of the patients come to us as doctors and they tell us that, doctor, it is very difficult to sleep. Guide us about sleeping posture on the operated side. How long can we sleep on a recliner-like position? So what do you suggest to your patients?
Okay, well, Dr. Akram, the patient should not sleep on the affected side for the initially first 6 weeks. Because during these 6 weeks, we expect there's some inflammation and some swelling is on the patient side. And the sutures means is surgeries. So you expect patient having a lot of pain on the side, and then we allow the patient can be lie down on the non-affected side, or semi means the quarter turn. So try not to lie down, and ask the patient to put the pillow. If he's lying on the non-affected side, if his arm is tired, put the pillow between his arm and chest, so he can rest his arm on this side in like a sling position, so make his comfortable. We understand from the patients, like this is quite difficult for the patients to sleep on one side, so he can change like the supine position, face up, and with the unaffected side, but should not sleep on the affected side. So try to avoid it, and the purpose is to reduce the pressure on the affected side for the first 6 weeks. After 6 weeks is over, patient is more stable, his shoulder is getting some movement, and his sling is removed, and his pain is definitely much lesser. We allow him to gradually can put bit of stress and can sleep on this side, but not fully put fully weight on the side. So this is the advice normally we can give to the patient, these type of patients.
Thank you, Vineet. Now we'll move on to our next case. Next case is of nerve repair. This was a 27-year-old male, had a glass cut injury, distal part of forearm, right forearm 2 weeks ago. Patient was sutured elsewhere without exploring the inside the wound. Afterwards, patient realized that he has a numbness over thumb, index, and middle finger. There was a weakness of thumb. On examination, there was a healed scar on the volar aspect of right forearm. No sensation on lateral 3.5 fingers, weak thenar muscles. Ultrasound was done, which showed that there was a complete transection of the median nerve. So patient was taken for exploration and the repair. Because it was relatively fresh case, so end-to-end repair without tension could be done. Here we are showing that magnification helps, and this was a kind of repair, epidural repair was done. And this is how we keep our orientation also, that there's no twisting. So coaptation between nerve fibers are good. So after post-op, patient was immobilized in 10 degree of flexion. Below elbow slap was given. 10th post-op day, first visit OPD, the dressing was done. Thermoplastic splint was given in neutral position. Our patient was sent to our occupational therapist with instruction that there should not be any dorsiflexion for 3 weeks, so that we don't want stretch on the repair side. Some mobilization and sensory integration was advised. Now I'll ask Dr. Sheetal to tell us what was done in the case. Over to you, Sheetal. Sheetal, unmute yourself.
Thank you, sir. I'll be telling you about sensory re-education of the nerve.
In the meanwhile, anyone has any question about the surgery, about the patient? Sheetal, you can share your screen.
Yeah, I'm just sharing the screen. Okay, this is sensory re-education of median nerve at distal forearm.
Your screen, we cannot see your screen.
Just a minute.
Yeah. We can have a slideshow.
Sorry for the inconvenience. Thank you so much,
Okay,
sir.
you can come on slideshow.
Yes, sensory re-education. I'll be telling you about sensory re-education of median nerve at the distal forearm. A median nerve is one of the prime importance for functioning of the hand. It innervates the group of flexors, ponator muscles in the forearm and the hand. Wasting of muscles is seen normally in a forearm and a thinner eminence. So you can see it looks like this.
Sheetal, you can come on slideshow. You can start, otherwise your videos won't work. From beginning,
Just
from
a-
beginning, from beginning.
Yeah,
Cancel. Yeah,
Is it clear?
yeah.
So, as I told you, I was talking about sensory re-education of median nerve at the distal forearm. This nerve is of prime importance for functioning of the hand. It innervates the group of flexors and pronator muscles in the forearm and the hand. In this, normally a wasting of muscles is seen in the forearm and the thinner eminence. So you can see in the figure, this is the wasting at the thinner eminence. Here the thumb becomes weak and is not able to grip the objects as abduction and opponents of the thumb is affected. Now, the pointing sign or the hand of benediction, they are quite similar. It is, in fact, they are same. It is called a hand of benediction, but since all the fingers are able to flex, expect the index finger, so it's called pointing sign. Deformity. When one tries to extend the hand, there is an ape hand deformity seen. Now, as far as the sensory re-education is concerned, in this, first of all, a dorsal block splint and an opponent splint is given to the patient to be used alternatively for 2 to 3 weeks with caution to avoid any further sensory loss to the affected area. As you can see below, both the splints. Even though the thumb and the wrist is restricted in the splint, one should avoid exposure to heat and sharp objects. This is very important. A fly limb is kept in sling. Sensory gain due to nerve innervation can also be affected due to myocystic contractures and tendon adhesions. So we ask the patient to keep the fingers as much as possible in the splint, especially the little finger and the ring finger. Till the time the hand is in splint, we try to prevent any stiffness in the ulnar side of the hand by again asking the patient to move the fingers as much as possible. As far as the desensitization technique is concerned, in this, it is a reawakening of sensation in the muscle, which is re-innervated by the nerve. We consider the following points in this while treating. First is the gate control theory, then is the mirror therapy, biofeedback mechanism, electrical nerve stimulation, 2-point discrimination test, and the cortical plasticity. First is the gate control theory. In this, the pain signal takes time to reach the brain after generation. This concept is used by giving a non-painful stimulus, which closes the nerve gate of the painful stimulus. So we use this concept, thus preventing the sensation of pain to travel to the central nervous system. Mirror therapy. It is used to preserve or reformation of cortical representation in the brain. In this, patient's affected side is reflected in the mirror and the normal hand is placed towards the opaque side. The patient is asked to perform activity on the affected side, which is reflected in the mirror. So the brain registers the reflecting image as normal side of the hand, and as a result, the affected side also performs the same activity. Here you can see the patient. We are making them do the mirror in the mirror effect. This is the affected hand of the patient. We've asked them to squeeze the ball. Now is the biofeed mechanism. In this, we bring results by visual and auditory stimulus to decrease muscle tension and pain. It is normally summarized as LOAF. That is lumbricals, opposition, abduction, flexion. Then is the electrical nerve stimulation. In this, the re-innervated muscle and end plate is stimulated to improve the sensation in the affected area. While giving stimulus, we keep the duration short to avoid any fatigue or injury to an already healing muscle. Then is the 2-point discrimination. Basically, this is a test. It is done to see that if the patient is able to identify the surfaces of 2 fingers while we are treating the patient specially. So they touch each other and there's a different feeling. They should both not feel as one. Cortical plasticity. We make the best use of cortical plasticity. In this, we give early sensory re-education to maintain the structural and functional representation in the brain. It also helps in controlling neuropathic pain. There are also other methods which are used. That is rubbing with the comb. We can start with the soft one and go to the hard one. Then is rubbing with the cloth. We can start from super soft and go to the super coarse. Then is brushing with the toothbrush. Again, here also we can go from soft to the hard one. Then we can use a mild cold and lukewarm water. One has to be very sure that a patient should not be uncomfortable while using ice or warm water, since it should not hurt the patient or increase aggravate the sensations. Then tapping, mild to moderate again. Then we can also give vibrations by the vibrators available in the market. You can see the patient is very comfortable in taking it. A very important thing, while doing these things, we should keep in mind that it is being done in the comfort zone of the patient so that it does not aggravate unwanted sensations like burning or tingling. To summarize the whole, emphasis should be laid on early sensory re-education. A structural rehab program is very important to achieve full function in the reconstructive nerve. Only re-innovation will not help in overcoming full functional movement in recovering from sensory loss to the organs without innovation of sensory input from the external source. Guide the patient to follow the precautions judiciously. A neuropathic pain management is very important as he might lose interest in getting it treated any further. All this helps in building courage and confidence and recovering from the said injury. There's a message to take back. It is a long process, not very long. Surely it takes merely from 4 months to 2.5 years to come back for the nerve sensations. So your speed does not matter. It should be in the comfort zone of the patient, but a forward is always a forward. Thank you so much.
Any questions to Dr. Sheetal in the meanwhile?
So if there are no questions, can we proceed to the next case?
Sure. Dr. Akram will present the next case.
So our next case is a case of trauma. He was a young 42-year-old, if you call him young, sustaining injury to his wrist, injuring his lower end of radius, came to us with this X-ray. You can see lot of comminution, AOC3 type fracture, both volar and dorsal cortex is injured. On CT, you can see smashed intra-articular fracture. We decided to operate upon this patient and we were able to achieve decent reduction, and we applied a volar plate. So on 5th post-operative day, dressing was changed and rehabilitation was aimed. With this message, we are sending a patient for physiotherapy. A young male comes to us with comminuted injury of his dominant hand. Fracture was stable after fixation. Intraoperatively under anesthesia, after fixation of fracture, both radioulnar and radiocarpal joints are good. Because he is young, there is no issue in quality of bone. Now I would like to request Dr. Rajiv to present a talk. How will he rehabilitate post-operative case of fractured lower end radius? Dr. Rajiv, over to you. I'm stopping my screen.
Okay. Thank you, Dr. Akram. So, first of all, please allow me to stop my video and I'll share my screen. Just a minute.
It's 20 hours.
Sorry, I'm getting some time. Please allow me to.
In the meanwhile, anyone has a question?
questions to any of the talks?
Dr. Sheetal? Question to Dr. Sheetal?
Yeah. Shashi, can
Yes, I'm
How
here.
long it heals to take median nerve? Healing time I am asking about.
Basically, there's no specific healing time, but yes, as far as we have been seeing the patients day in and day out, I have seen that the improvement comes as early as in 4 weeks and as late as 2.5 years. So that's the maximum time what I've seen.
I would like to add, Shashi. So healing time would also depend upon the level of injury. So distance between the tip of finger to the site of injury is important. Okay. So the more proximal the injury, the longer is the healing period. Isn't it? Sheetal would agree.
Got it. Yeah.
Yes, exactly.
Okay,
So-
sir, I'm ready.
Yeah.
So shall I start now?
Yeah. Rajiv, we can start.
Okay, sir. So my topic is physiotherapy management of distal radial fracture. So I got a case referred by Dr. Akram, and with following notes that he has operated 142 years old male with comminuted fracture of distal radius. Can refer of that patient. See the bone. So
I think there is some technical. Rajiv.
yes, sir. Shall I
Yeah, you can start now. Is it okay? Yeah.
again? Yes, sir.
Is it okay, or otherwise we can move to so that
I'm ready. Can you see my
We
slide?
can see your screen, but we are not able to listen to you.
your voice is not clear.
Sir, can you hear me?
What we will do, Rajiv?
If you can hear me, I can. Okay, sir. Can you hear me now?
Yeah, better.
Can you hear me, sir?
Yeah.
Okay, sir. So, just my previous slide, I would like to just remind again that I got a referral from Dr. Akram with following notes that there was a case of comminuted flexion and internal fixation with volar plating. During surgery, he found that bone, muscle, tendon, and nerve were in good condition. And at the time of suture, there were no instability in fixation, as we can see right side on the slide. So on fifth day, the patient came to doctor for bracing, and he found now this is the right time to refer to physiotherapist. The patient came day one in physiotherapy department. So when patient came, I discussed with him and set some goal that why we are doing this, because he was a non-medical person. So I wanted to explain him what will be our physiotherapy protocol. So I explained him we are doing this to avoid muscular atrophy, reduce edema and pain, improve circulation, restore full range of motion, gain full muscle power, improve skin integrity, and finally able to do activity of daily living. So I divided my physiotherapy protocol in two parts because immobilization phase, the period was 0 to 2 weeks, and mobilization was 2 to 12 weeks. So let's start with immobilization. So first day when patient came, I told him you have to visit physiotherapy clinic thrice in a week, and you have to do some light use of your affected arm, very light use. You have to keep your arm elevated for swelling control, and you have to set a realistic goal and realistic expectation. And if you feel any problem, any difficulty during this physiotherapy session, you need to communicate with the surgeon and therapist. So then I started exercises. First, I started with active finger flexion and extension. You can see right side on the slide. And active thumb opposition to each fingertip. Some passive deviation, then passive supination and pronation. It was very important that elbow should be flexed 90 degree. And I taught him all these exercises and told him that you have to do all these exercises at home also, and the repetitions should be 10 times and 3 times in a day. Then we came to mobilization phase. Mobilization phase divided into 3 parts: early phase, middle phase, and late phase. Early phase was for 2 to 4 weeks, middle phase 4 to 6, and late was 6 to 12. So now I will explain you how I did exercises on these 3 phases. And so once a splint was removed, I started the splint. So first I did active range of motion with scar muscle.
I think there's some problem in the internet.
Yeah. So can we move to the next talk?
Yeah, we'll move to the next talk. We'll move to the next talk. In the meanwhile, any questions?
I have a question for Dr. Shashi if he's awake.
I'm sorry, I think I lost my connection.
We'll have your talk. We continue. In the meanwhile, what we will do, we'll go to next. You stop sharing the screen.
Okay.
And meanwhile, you just see what is happening to the connection. We can continue towards the end. Is it okay, Rajiv?
Yes, sir.
Yeah. We'll move to our next case. Next case is arthroscopic Bankart repair, which was when a patient came to us. This is a 23-year-old active male. Active male presented with the recurrent dislocation right shoulder. First dislocation happened 2 years back. Total number of dislocations was 6. So there were 6 episodes of dislocation. Every time a patient was able to get the reduction, close reduction. First reduction was done under GA. Subsequent reduction did not require GA. When patient came to us, we examined. On examination, apprehension sign was positive. On MRI, there was a Bankard lesion. On CT scan, there was a 18% bone loss on the anterior aspect of the glenoid. Young patient, recurrent dislocation, high demand patient. So we plan to do a arthroscopic repair. This is arthroscopic, showing there's some amount of bone loss in the glenoid on the anterior aspect. Plus, you can see there's no labrum attached to the glenoid. So what we do, we first release the labrum, which has gone from the rim of the glenoid to the neck of the glenoid. So we have to release it so that we can put it back to its original position. So once we have released it completely, then only we can reposition the tissue. So this is how we release. Then we freshen the margin of the glenoid. Otherwise, what will happen, the healing won't take place on the cartilage. So we have to expose some part of the bone. Once we expose a part of the bone, and we have to use shavers to bare the bone and debride the edges so that there's a bleeding bone there. So with the help of a shaver, you expose the bone. Once you have exposed the bone, we use radio frequency to smoothen everything. If there's any bleeding area, we can stop bleeding also. We smoothen everything with the radio frequency. So afterwards, with the help of a rasp, we just get the bleeding bone. So once there's a bleeding from the bone, the chances of healing are more. So next step is to see whether whatever release we have done, whether once we are doing a repair, we are able to put this tissue back to its original place. So once we are satisfied with the amount of release, then we start taking bites into the tissue. This is how we take bites. This bite was taken from the posterior portal into the inferior 6 o'clock. So first tear is taken and retrieved into the anterior inferior portal. Then we use anchors. Anchor is used. This is bioabsorbable double loaded anchor, what we use nowadays. So what happens, for each anchor, you can take 2 bites. So there can be 2 knots for each anchor. So this is a second bite taking into the tissue. Once you have taken the bites, when you use a thread, the tissue sits on the bone. This is how repair is done. So anchor is into the bone. Once you tighten all these threads, the labral tissue nicely sits on the glenoid margin, which allows it to heal. So this process is done repeatedly 5 to 6 times, depending on amount of lesion. So 5 to 6 knots are taken. Once we are happy with it, we close the wound and patient is discharged on a sling or shoulder immobilizer. Patient comes to the OPD 5th day, dressing is done. Patient is referred to physiotherapist with the following information: that joint is stable, repair quality is good, but we ask them to avoid abduction, external rotation for 4 weeks. After this, we refer the patient to Dr. Rathore. Dr. Rathore will now tell us, Amar will tell us about what he did next. Over to you, Amar.
Okay, thanks to Dr. Vikas. Now I'm going to share my presentation, which is on the topic post-operative arthroscopic Bankard repair. Here is some sort of past experience, and we have to monitor post-operatively 5 points. Those are swelling around the joints, abnormal pain responses, hypersensitivity, increase in night pain, and weakness of the upper limb muscles. And physiotherapy can be divided into 4 phases after first week. In first phase, which is started from first week to 3 week. Here our goals are to promote healing, control pain and inflammation, gradually try to increase range of motion, independent, try to educate patient for home exercises program so that they can do independently, and initiate muscle contraction. For first 6 weeks, sling is important, and for pain relief, we are suggesting ice pack to the patient. Exercise program for such patients are passive range of motion exercises in scapular pain, and external rotation should be within 10 degree, or by 3 weeks, we can increase up to 20 degree. Internal rotation can be move up to 45 degree, and by 3 weeks we can move up to the 60 degree. And similarly, a passive range of motion exercise for flexion should be 60 degree initially, and later on we can move up to 90 degree by the 3 weeks. And other exercises which we have to consider here, pendulum exercises, posterior capsular stretching, and manual stretching. For pain relief, we are doing grade 1 and 2 mobilization, and there should be no active external rotation or abduction or extension exercise at this stage. We have to initiate submaximal isometrics to decrease the pain of in pain-free range. Here we can see one of the pendulum exercise for the flexion, which we are suggesting to the patient. And in next video, we can see how we are doing passive flexion with support. Now we can move to second phase. In second phase, which is from 3 to 6 weeks, here our goals are to control pain and inflammation, enhance upper limb strength, and gradually again we have to try to increase range of motion. And by 6 weeks, we can discontinue our brace, and ice pack we can continue for to decrease pain. Exercise program at this stage are, now we can start active assisted range of motion exercises for the scapular in scapular plane, and external rotation can be moved up to 30 degree by 6 weeks, and internal rotation can be moved up to 90 degree by 6 weeks. What we are doing in our practice. And passive range of motion for the flexion and elevation, we are increasing up to 140 degree if patient allows for this. And other exercises we are suggesting and also doing prescribing to the patient, that those are pendulum exercises, posterior capsular stretching, and manual stretching. Here we can or we are doing grade 2 or 3 joint mobilization to the patient to decrease pain, and simultaneously we have to increase the joint range of motion of the patient. And here in this stage, we can start external rotation, abduction in scaption plane, and rope or pulley exercises can be started. Band exercises can be done in all the planes within the pain-free limit. We are also doing some isometric exercises as in phase 1, and we are also doing supine rhythmic stabilization at 90 degree flexion. We are also considering upper body exercises for endurance, and in sideline external rotation and prone horizontal abduction, we are starting to the patient at this stage. And flexion and empty can, we are starting in this stage in scaption plane, and scapular stabilizer strengthening exercises we are also doing in this stage. Here we can see for the horizontal abduction video, and in second video we can all see that grade 2 and 3 mobilization to increase the joint range of motion and simultaneously to decrease the pain. And in phase 3, which is started from week 6 to 12, here our goals are to check the pain and swelling and increase range of motion of the joint and improve upper extremity strength and endurance. Here we are adding endurance also, and we have to enhance neuromuscular control and also check the orthokinematics of the joint. Here our range of motion goals are quite increased, and here we by 10 weeks we can or we are what we are doing in our practice, we are increasing range up to the maximal, that is maybe a full range of motion. And all the exercises what we are doing in scapular plane at this stage. External rotation we are doing in 90-degree abduction, and 0 to 75 degree by 8 week our goal is to achieve. Passive range of motion exercises and active range of motion, active assisted range of motion exercises for flexion are what we are doing. By 8 week we are trying to achieve 160 degree. Other exercise programs include we are also adding Lyotos chest pass by week 8 to 10, and we are also adding a PNF with TheraBand at this stage. We are also starting a PNF in supine position with manual resistance, with minimal manual resistance initially, and we are also doing isokinetic internal and external rotation by 10 to 12 weeks. Here we can see one of the video, third stage, how we are facilitating external rotation at 90 degree. And in next stage, here we can see how we are facilitating abduction in scaphoid plane. Now we can see that patient is able to do itself abduction of the shoulder in scaphoid plane. Next stage is fourth stage, phase 4, which is started from week 12 to 24. Here our goal are full range of motion we have to achieve, and what we are doing, we are able to achieve the full range of motion of the joint. We are also here trying to increase strength and endurance and try to achieve maximal strength and endurance. We are trying to achieve a maximal neuromuscular control. We can also start sports specific activities what we are doing in our practice. Here our exercise program is to attain all the range of motion of the joint. Posterior capsule stretching we are also continuing at this stage, as extension is more prone to less to achieve and difficult to achieve. And here we can add to the patient that we can suggest to the patient that they can do towel stretching exercises at home. And grade 3 to 4 joint mobilization we are given to the patient to achieve full range of motion. And other exercises are to we can add high speed repetition exercises with resistance. Eccentric strengthening exercises we are adding in our practice. Single arm Lyotos, rhythmic stabilization, standing in PNF with tubing we are doing in our practice. And other exercise programs we are adding in our practice are upper body exercises for strength and endurance, military press, bench press, lateral pull downs, and sports specific drills we are doing in our practice. Interval throwing program at week 16 we are initiating in our practice. Light plyometric exercises we are starting in 12 to 16 weeks, and isokinetic exercises to 90 degree abduction at high speed we are also initiating in our practice. Here we can see lateral rotation with tubing, how the patient is doing. And here patient has to move both the arms away from each other. In next video, we can see PNF, how we are doing PNF in our clinical practice. So we were just initiated this exercises. It was his first sitting. So it is difficult for patient to learn. And after 1 or 2 sittings, the patient is able to learn these exercises and they can easily do it. Now we can see that after 2 repetition, he is able to do this exercise with high resistance. As we were added some resistance, so it was quite difficult for the patient to do with that therapy. At last, we have to consider that what should be avoided during the rehabilitation protocol. We have to avoid pull downs behind the neck, wide grip. We have to avoid behind the neck shoulder press. We have to avoid wide grip bench press, standing lateral deltoid raises, triceps press overload. At last, here I am presenting some references what I was taken. And now, thank you, please.
Thank you, Dr. Amar. Any questions to Dr. Amar?
Yes, sir.
And meanwhile, we'll ask Rajiv to start from where we had left. So Rajiv, you just come to the slide where you had left. Any questions, Shashi? Any questions to Dr. Amar?
Amar,
Yeah.
how will you train and when will you train patient changing the shirt and t-shirt? What is the procedure that you teach the patient to change their tops?
Pardon?
Do not allow abduction and external rotation. It must be difficult for our patient to change their dress.
Yeah.
So how do you train them? Can you throw any light on that?
Initially, first 6 weeks, as patients are quite careless practically. So we are trying to avoid those things, and we are teaching to them they should take some assistance of someone. So sometimes if you are allowing for 10 degree of some movement, what they are doing, they are trying to doing themselves. So we are not.
I'll interrupt, Amar. I'll interrupt here. I'll interrupt here. Actually, Dr. Akram is asking, what will you instruct? Simple instructions that when patient is wearing his shirt or it should be open from front, and affected hand should go first and unaffected second. And when he's removing, affected should be second and unaffected should be first. So I think, Dr. Akram, that was your question.
Yes, that was my aim, to tell everyone that this is a very important part in personal care. We must instruct, all physiotherapists have the responsibility to instruct patient about dressing, undressing, what care has to be taken even after bank cards or maybe rotator cuff repair for that matter.
So Rajiv, are you ready?
Yes, sir, I'm ready. And
Okay.
I would like to say sorry for the inconvenience caused.
It's okay. It's a technical thing. Don't worry. It's a technical thing.
So I'm just stopping my video for the better network thing and voice clarity. And as I mentioned that I got a referral from Dr. Akram, and the case was comminuted fracture of distal radius. I was talking about the management because I explained everything to the patient. My physiotherapy protocol was divided into 2 parts, immobilization and mobilization. The immobilization phase was for 0 to 2 weeks, and then mobilization phase was for 2 to 12 weeks. So start with immobilization. I physiotherapy clinic thrice in a week, weak. Hand for very light work, keep arm elevated and set realistic expectation. I did some exercises that active finger extension and flexion, active thumb opposition to each fingertip, passive wrist flexion and extension. You can see on the right side the radial and ulnar deviation, and on the bottom right, passive supination and pronation. Here, one thing is important that elbow should be 90-degree flexion position. I taught my patient that they should do 10 repetition of each set, and he should repeat all these exercises thrice in a day. So this was the immobilization phase. Now in mobilization phase, I divided into three parts: early phase, middle phase, and late phase. Early phase was for 2 to 4 weeks, then 4 to 6, and 6 to 12. Now you will see that how exercises got changed in all those phases. Early phase 2 to 4 weeks, I advised my patient to keep wearing the splint. With goniometry, I measured active range of, you can see on the right side bottom, and his elbow and shoulder was not involved. So I did some strengthening exercises of elbow and shoulder joint muscles. Then I gave him a foam ball to squeeze, and I did active assisted wrist flexion and extension, active assisted radial and ulnar deviation, and I gave him some homework, basic homework like tearing paper. Then I did in the next week isometric exercises of wrist joint muscles, some finger movements with mild resistance, figure of 8 at wrist followed by rhythmic and fine movement. Gradually they have to make better movement, and passive followed by active assisted supination and pronation, which was most important initially, do with passive. Now we came into middle phase, that was for 4 to 6 weeks. Here I started with hydrocollateral pack. It was for 15 to 20 minutes to relax the muscle and nerve and to better perform the exercise. Then I did some retrograde massage left side. Then slowly we started some wrist flexors, extensors, adduction, abduction, supination, and pronation, all these in active mode. I gave him some dumbbell and TheraBand to do some exercises, and then we came into the late phase, that was 6 to 12 weeks. Now exercise regime was which you can see on the right side top in the screen. Then progressive resistance exercises. I increased the weight gradually, and TheraBand flex bar exercises I added, which you can see in the picture, right side bottom. Here I focused on again elbow and shoulder exercises and resume pre-injury activities like cooking, driving, sports, etc. So in the last, I would like to show you with a slide that what was the progression of exercise. You can see with this chart how exercises got changed from 2 weeks to 4 weeks and 4 to 6 weeks. On the left side, these are the movements. For example, if you can see anyone like ulnar and radial deviation, 0 to 2 weeks, I was doing passively. Then in 2 to 4 weeks, I started doing active assisted. 4 to 6 weeks, it became active and then resistive. And in the last, you can see that initially I did not do any stretching. 2 to 4 weeks, mild stretching, then moderate, and after 6 weeks, full stretching. Similarly, closed kinetic chain exercises I added in the last. So this was my whole progression of exercise, which I showed you in my previous slide also with photos. And the expected outcome was the patient wrist was normal, and we restored maximum potential. He was able to do activity of all daily living, and I advised him to continue all those exercises which I taught. And if there is any difficulty, problem, consult to the surgeon or therapist. So this was my presentation.
Thank you, Dr. Rajiv. Thank you, Dr. Rajiv. So we can say any questions to Rajiv or any of the participants? I was from the YouTube. I'll have few questions. One question for Dr. Sheetal from Pankaj. Why there is so much stress on the 2-point discrimination and why it is important?
There is stress on the 2-point discrimination because especially in the children's, they are not able to identify in fact what percentage of sensation is they are getting. So they are very vague in replying. Even the elders, it happens. So we do 2-point discrimination just to know that their feel on both the fingers is different. Like the feel is there. It is not that the feel is there only in one finger and the other finger is not there. So this makes us clear the situation.
One second, let me interrupt. 2-point discrimination recruits more number of fibers so that more number of fibers have healed. So your 2-point discrimination distance decreases. So it is a very sensitive method of nerve healing. So 2-point discrimination tells us the lesser the distance between 2 points. Like, okay, by 2-point discrimination, we mean that when we touch 2 points, the patient should feel them individually. Like he should feel as 2 points, not as a 1 point. So if 2 points are very close to each other, then patient will feel as one. As nerve heals, as more and more fibers are recruited, that sensation becomes more fine and the distance decreases. So that was a question why I put it up, because it was on the YouTube. So I think that makes it clear. It just tells us how nerve is healed, the amount of number of neurons which have been recruited. It's you can say, more finer way of testing the sensation and recovery. Akram, you want to say something?
Yeah, similarly on 2-point discrimination, it's a diagnostic test to evaluate the quantity of healing. It is a diagnostic test to evaluate the quantum of healing. If 2 points are coming closer on same digit, that means the more neurons are being recruited and healing is progressing at its normal pace, at its expected pace. If the distance between these 2 points, or the patient is not able to reduce the distance between these 2 points, that means the healing is not progressing. So it is very important to check 2-point discrimination weekly to assess healing of sensory symptoms.
Any other question to anyone?
Question for Rajiv. Rajiv, you did not mention anything about what will you ask patient not to do in first 6 weeks. Okay, you said I will promote healing, I will do scar mobilization, I'll ask the patient to move. What will be a big no from your side to the patient? Yeah, don't do this except do everything.
Few things we can do, like the first thing is supination and pronation he should avoid, and don't try to lift any heavy weight, and keep the spleen any further injury or anything you can. I think that is the thing.
What about getting up from chair or bed? Is he allowed to push
Yes.
himself up?
No, yeah, that is the main point. Like, it is better not to use that affected arm to getting up from the chair or the bed, and better to use unaffected arm.
Okay, thank you. Thank you very much.
Any other question to anyone? Otherwise, we'll call it a day. I'll thank all the speakers for taking out time, and presentations were good, except for a little bit technical hitches, which were like not in our control. Otherwise, everything was good. So I thank you all. And before I leave, I thank Dr. Akram. Thank you. In the meanwhile, I'll like to say thank Mr. Ram. He has been a technical support behind the scene, making everything possible. We didn't have any sponsor, or we didn't outsource anything. It was everything is done in-house. So technical support is in-house. Thank you, Ram. So
Thank you.
before we leave, I thank you all. Thank you.
Special to those who are waking up at this hour, particularly Shashi, Dr. Shashi.
It's 3:10 a.m. So, but tomorrow is Sunday. Today is Sunday, in fact, so no issue.
Okay, good luck. Good luck. Good luck, everyone. Good night.
Okay.
Okay,
Good night.
bye. Good night.
Thank you. Bye.
क्या हो गया? तो just सिर्फ मेरे को शट डाउन करना है। क्या हुआ? मेरा लास्ट मोमेंट पे मेरा लैपटॉप बंद हो गया। क्यों? बैटरी में चार्ज नहीं किया। बेटा कोई बात नहीं, हो गया।